So this is the pterygoid anatomy. So what we observe? So this is the tuberosity, right? This is the pterygoid plate. This is the pterygoid junction. This is our target area. This is the sinus. And if you see, this black is air. But here it is grey. That means it is not normal. Yeah, thickening or granulation tissue, we don't know. Maybe abnormal thickening. For this patient, more thickening on left side than right side. So now we have to start the drilling. So this is the pterygoid hammer notch. During border molding, we used to feel this. So feel that hammer notch. In front of the hammer notch, start the drilling.
Yes.
Starting point. So first thing is starting point. Where will you start the drilling? Second thing is how much distal angulation you are going to give.
45 degrees.
You are not going to give mesial angulation. You are not going to give vertical angulation. Definitely there is some distal angulation. So how much distal angulation?
40
to
50.
50. Yes, roughly. So 40 degrees. Third one is palate. These three things, pterygoid is done.
10 to 50 palate.
So we will place the implant. So this view, same view you can get if you take IUP.
Yes.
Do the drilling,
Yes.
not fully.
Okay.
Keep the drill and take IUP.
Okay.
Then you will understand whether we are going into the sinus or into the correct path or going to distal. Then change the direction and take another IUP. So during pilot drilling, take repeated RVGs.
Okay.
You will never miss the pterygoid. The only thing we don't know is how much palatal angulation.
Oh.
So for எல்லாத்துக்குமே we can take pilot drill put
Yes.
correct direction.
Mesodistally you are safer. RVG. Buccolingually, open the flap, you are safer.
Yes.
If you open the flap buccolingually, if it is coming
Even sir, lingually we can open the flap till mylo hair reach or not.
no need. Just finger palpation enough.
Below mylo there is.
Don't go beyond myloid because you will be stripping the myloid muscle, which is not reason. Okay. Till myloid reach you can go, but don't go beyond. It is not necessary also. Because here the palpation is very easy. It's very superficial for palpation. But here the thing is you cannot surgically see this area. You cannot palpate this area. These are the two things. You cannot palpate with your finger. You cannot surgically see it. Only sensation. When you are drilling, you will feel this resistance. At one point of time, you will feel the drop in the resistance. So, drill dropping. Drill drop is a kind of CBCT for us. Drill drop.
Here is a drill drop.
Yes, you will get the drill drop. Pterygoid junction after you go beyond the pterygoid junction for the model form.
Is anyone faced bleeding in this area?
No, it is not a major issue because our maximum implant length is only 20 mm. So the dangerous area is more beyond that. Even if you plan to do some bleeding, it is difficult to do. So make sure your drilling depth is not beyond the 20 mm. Then you are safe. Even if you go accidentally into greater Perthen canal, the bleeding is manageable. The compression most of the horizontal bleeding
length is small.
Yes. See, there are two reasons why bleeding comes to pterygoid. One is when you enter the sinus some vessel, it will lose.
Sir, if you accidentally perforate the sinus, so nothing happens. But change the angulation, correct the angulation, raise the implant, is suture.
Yes. Sometimes
Even laser floor, sir.
Nothing.
So why
I've done some
you
schema system work.
and all?
Yes, we never do sinus lift for
Not for this other thing.
For single to three infection can do.
Infection may hurt karna, they don't have the
sinus lift is nothing but lifting the floor and keeping the bone there.
Both the maybe to increase the height.
Height, yes.
I anything like related to infection because we place everything inside the nothing.
Only if you place foreign body in the sinus, it will get infected.
Otherwise,
Implant is not
tighten. So just
unless
to
patient
increase
has
the
a history of
height, they are doing sinus.
unless patient has a history of sinusitis, the regular sinus, it's not indicated to do sinus lift also in that case. एक केस है सर मेरा चालू क्रिस्टल का 2 इम्प्लांट डाला अभी 4 दाना तो डायरेक्ट क्रिस्टल ये डाल देता फिर बेसल ही कर देता
बेसल
हाँ बेसल ही कर देता हूँ मैं क्या पेशेंट को 3 महीने चढ़ाने इधर अपर है साइनस लिफ्टिंग उसका भी है सीबीसीटी एक्सरसाइज
Buccolingually, if you see, the bone resorption has affected the pterygoid area also. Buccolingually, it is very thin. Okay. So that will be a challenge during surgery. So the right pterygoid is very similar. So this is a greater palatal canal labus.
Yes.
In case if the drill goes into that area, but it is not a major thing. So if you see, the important observation here is
O2 है O2 O-flux only resolve O2
it will be less.
O2 अभी पैंड ही लिया था थोड़ा गैस्ट्रिक अपसेट जैसा लगा बहुत ज़्यादा नहीं
O-flux is in?
O-flux is in only resolve O2
So if you have welder, it will be useful for both whether conventional implants 2.5,
2.5
but it is okay.
So it's only used in basal implants or else?
In between 1 or 2 years we mixed conventional also, but later having lot of stroke and armamentarium, so keep it simple. Now 100% is single piece, cemented and screwed. So if possible, we can place an additional implant here. Right? Palatal approach. Palatal approach is the savior for many situations. So instead of drilling like this, you will left with no bone palatally, no bone buccally. If you drill palatally, at least you will get 2 mm bone buccally. Palatally, you don't need bone. Even conventional implant, there will be many cases like that. There are many articles for this palatal approach.
So you do basal since
2008.
2008. Yes. Sir, what you say? मतलब I do conventional, but मतलब due to within 3 days, मतलब even single tooth or bridges, मतलब what you say? Do conventional or basal? Which is better? As
So slowly you try this also. Slowly you can incorporate basal also.
basal and basal.
Don't stop conventional fully.
Okay.
Selected cases where you are confident, you can try basal also.
And sir, like diabetic hypertension, mainly diabetic rheumatoid arthritis, or the patients on steroids, or
Diabetic and all without any
smokers, even smokers, chain smokers, on
provided they are taking care of the blood sugar level control, HbA1c level.
That should be below 7.
Yes.
Below 7, even in basals.
Yes.
But success rate does not affect them.
No. There is no relation.
And packages, how are the packages of basals and
For patient or telling?
No, this company, 13 counts.
I don't know. I will tell the person to come.
Come.
Probably
Tomorrow.
We can discuss. Bye. This is the pterygoid. So the implant is reaching the pterygoid. Here it is in the medial and lateral pterygoid junction, but it is here slightly towards the lateral. But that is not a issue. It won't be a major issue. Here everything is palatal approach. You can see, no, the labial buccal bone is outside. Buccal bone is outside. Okay. We'll see the anterior implants. See, this is 4 into 8. It has not perforated the nasal floor. So we can use a longer one. 2 mm into the nasal floor, no issues. Actually, when you place, no, it was little soft sensation. This is 2-1. It is okay. It is 1.5 mm into the nasal floor. The nasal floor has been elevated. That is okay. This is nasomaxillary buttress area, palatal approach between nasal cavity and the buccal bone. It is going good. Even 2 mm, 3 mm, we can go still more also. We can perforate here also. We can go in. We can select a 3.75 into 18 also. Here also it is going good. Palatal approach went till the sinus floor. We can finish it. The only thing we have to change is this convert into 10. So that we will go into the nasal floor. If you have time, we can elevate the nasal floor and we can visually see also. That is